So we are nowhere near that in East Kent. We started the hFRenDs, I keep calling it hFRenDs because there's a H at the beginning, and I keep getting told off, it's friends. Didn't mean to do that. We started Friends last year after this event, and so we are still very, very junior, but this slide deck will just kind of show you, how to get started with a Friends group. So I'll tell you a little bit about East Kent. So we have a population of 720,000 people, and we're seeing an increased amount of people over the age of 65. It increased by 11,000 last year. We have sea, we're surrounded by the sea, and people like to come to East Kent to retire by the sea, especially people from London. They'll come down to Margate and retire down there. So our number of people over age 65 is forecast to increase by 58% in 2036. And yeah, some of the parts of Thanet are really deprived. So we are among the most deprived in England. 21% of Thanet's population living in the bottom 10% of deprived nationally. So we've got lots of older people, and we've also got lots of deprivation. So we've got 5 hospitals, 3 main hospitals. So you have the big QEQM in Margate, William Harvey in Ashford, Kent in Canterbury is more sort of where the renal team are based, and more sort of longer stay patients. And then you've got sort of community hospitals, Buckingham Hospital, Dover and Royal Victoria Hospital in Folkestone. The renal team also cover they do clinics in Medway and Maidstone, and they do joint clinics with Guy's and King's in North West Kent, so they're spread across Kent, not just in East Kent. So we have 44,954 patients diagnosed with diabetes in East Kent, and 24,141 people that have pre-diabetes, so quite a big caseload of patients with diabetes. 27,973 people living with renal failure, and 5,917 people living with heart failure in East Kent. Diabetes team looks a bit like this. We've got consultants at each site, we've got young adult and clinics and transition at each site, we've got inpatient teams at the big sites, so Canterbury, Margate, Ashford. We have inpatient diabetes nurses, and I'm their sort of matron for those three sites. We have an insulin pump service, and we do clinics at each site, and we have community nurse clinics, which is run by our community team, KCHFT. And we're also doing this thing in Herne Bay. There's like a little pilot that's done by our community team again, KCHFT, where they're looking at taking the diabetes specialist nurse into primary care, so like the DIAS type model. If any of you have heard of that, if not, have a look at it. It's a really good model where diabetes specialist nurses are going into primary care and doing clinics with the practice nurses to upskill them and kind of stop those preventing them getting referred into the service. So this is our cardiac team. Lots of stuff going on in cardiac. They have heart failure outpatient clinics, community heart failure, cardiac rehab nurses, rapid access chest pain nurses. I'm going to pretend I know what all this means. So lots of stuff going on in cardiac and also in renal. So we've got 480 people on hemodialysis, 20 people on home dialysis, 19. Well, you can see all the figures there. I won't go too much into that. But lots and lots of stuff going on in all 3 services. So who's in our Friends meeting? So we got together and we decided we would, after last year, we thought we would get together, get everybody and just have a chat really and learn together and do some education sessions. So these are all the kind of people that showed up to our first meeting. We've got diabetes specialist nurses, community nurses, dietitians, heart failure team, community inpatients, you've got rehab nurses, arrhythmia nurses, you've got kidney transplant team, advanced kidney care team, so lots of different specialities that turned up to our first kind of meeting. So we started with an afternoon meeting. We got AstraZeneca to pay for, sorry guys, sponsor, a lovely venue, and we had a nice lunch, and obviously we had a talk, and then the rest of the afternoon was left for us to kind of plan stuff. So it worked out really well. Sort of half of it was an AstraZeneca meeting, and the other half was our kind of time to just brainstorm and kind of decide what do we want to get out of this kind of group meeting. We also did some evening meetings. We invited the consultants to those ones. We got them to speak so that we could learn more about each other's specialities, because we're not experts in each other's specialities, and we won't be, but we just want to kind of get to know, what happens in heart failure, what happens in anemia, what happens in diabetes. We got some outside speakers to come in and talk about complex cases. So we had a pharmacist from Leeds, actually, who come and talk to us virtually about managing blood pressure in people with all 3 conditions. So really complex patients, what can you use, what can't you use, and things like that. We had some brainstorming sessions and sort of planning, what should we do, where are we going to go forward with this? And the renal team decided that they would take on this really amazing challenge of learning how to initiate insulin. I think they're probably, I would imagine that one of the only teams that have done this, but they all went on a pit stop. So 19 members of the renal team went on a pit stop program, which is like initiating insulin. It's just a 3-day program, and they learn all about the drugs, all about insulin, and how to initiate. And our consultants in renal have actually started people on insulin. Amazing. And they've also learned how to do continuous glucose monitors and freestyle levers, so they now will put those on their patients without our help. They don't need our help to do that. They'll set those up. So well done on the renal team. If any of you are here today, I'm not sure. So the next steps, we're thinking about organising a pilot MDT meeting. The renal team are going to start it because they've got the facilities to kind of coordinate all 3. So they'll find people that have all 3 conditions, and we'll maybe have like an MDT discussion. We're going to do it virtually because, as you saw, all those people that come to hFRenDs, it's difficult to get them all together in the same room. Sometimes we do that meeting sort of 3 monthly, and we can do that, but if you're going to do something regularly, then virtual is probably a better way to go, because we can get people in just for an hour, talk about a few really complicated patients, and then zip off again to clinic and whatnot. So we're looking at fortnightly MDT for those really complex patients, and then maybe bringing in the consultant every now and then when we need them, the different consultants, obviously all 3 different consultants. We've contacted pharmacy, looking at getting their support in it, and we're thinking about opening our 3 monthly meetings up to the wider MDT, so getting primary care involved, getting, so it's not just nurses again, much like Care and Me want to get us involved, we want to get them involved, so we're just going to open it up a bit more so that we can get their views and their sort of ideas. And we're discussing what's this cardiorenal metabolic pathway going to look like. It's such early days, really, really early days, but even just talking together and meeting together and just getting those questions out there, what do we need, where are we, that's where we are at the moment. So we're going to need to do business cases, obviously we're going to need stats, we're going to need resources, obviously we're going to need money, there's never any money in the NHS, but if we can work collaboratively, maybe there are clinics we can work together on. So if so you've got a heart failure nurse doing a 20-minute appointment with a patient, a diabetes nurse doing a 20-minute appointment with a patient, and a renal nurse doing a 20-minute appointment. If it's the same patient, that's a 60-minute appointment. Actually, if we seal them all together, maybe there's a way that we can, bring our resources together to reduce the time and also the experience of that patient, not having to go to 3 different appointments, but coming to see one appointment and seeing all 3 of those together, so that we can kind of work, reduce that for the patient. We need to look at governance. Where do we stand with these really high, complicated risk patients? We need to make sure we've got all those systems in place, all those standard operating procedures, all of that kind of stuff. We want to know what our outcomes we're thinking are going to be like, because that's how we're going to get this business case running. If we say we will reduce XYZ by this amount, that they're more likely to get funding, we're more likely to get buy-in from our line managers and whatnot. And we need to work out, is it worth it? Is the cost going to outweigh the benefits, so we can prove, we can prove this is worth doing. And yeah, questions at the end. But I'll get on to the next.